Welcome to IMPACT's webinar series. IMPACT is a clinical trial training platform funded by the Canadian Institutes of Health Research to increase capacity for clinical trials with children and pregnant people in Canada. This webinar was developed for anyone who wants to learn more about clinical trials. You can share it and register online to attend future webinars live. Our free webinars will continue to cover cutting-edge topics in pediatric and perinatal clinical trials. To learn more about future webinars, visit our website www.impacttrials.ca. After the webinar, we invite you to check out other IMPACT Knowledge Hub resources on dual code. These include courses on a wide variety of introductory and intermediary topics in clinical trials. All IMPACT courses are created and peer-reviewed by experts from across Canada and provide certificates of completion. We hope you enjoy this free and educational content brought to you by IMPACT. To learn more about working with us, you can find our contact information online.
Okay, hello everyone, and welcome to today's webinar on integrating clinical trials into care, lessons learned from pediatric oncology. My name is Nancy Butcher, and I'm the co-director of IMPACT. We are really delighted that today we have Dr. Daniel Morgenstern. Daniel is a staff oncologist at the Hospital for Sick Children in Toronto and an associate professor at the University of Toronto and the head of clinical trials at Sick Kids. So the way we will run the webinar today is that Daniel is going to present for about 45 minutes, and then we'll have about 10 to 15 minutes for general questions from the general audience. Then we will have a 30-minute closed discussion period between Daniel and the IMPACT Fellows and the Trial Enrichment Group learners. If there are any learners on the call today from any of our other partner networks, like Rare Kids Can or Popcorn or others, or if there's other former IMPACT Fellows who are on the call who want to join in on this discussion period, please just send me or Chelsea a quick message and we'll make sure that you have access at the end of the call. You just advance the next slide, Daniel, please. Thank you. So before we begin, I just want to open today's session with a land acknowledgement. So on a national level, we encourage all Canadians and visitors to Canada to learn about the Indigenous people of the land on which they live, work, or visit, and become engaged allies together. We as Canadians, in the spirit of truth and reconciliation, respect the self-determination of First Nations, Métis, and Inuit, and their rights and responsibilities in cultures, languages, and the pursuit of wellness. It is now my pleasure to hand things over to Dr. Morgenstern to begin today's presentation. Welcome, Daniel.
Thanks so much, Nancy. Hello, everyone. Hopefully you can hear me okay. So we're going to be talking about clinical trials in pediatric oncology. These are my disclosures in relation to various pharma companies, but I don't think anything that directly impacts on what I'm going to say today. So let's just start. This is what we're going to be talking about in terms of the outline: cancer in children, what it is, how common it is, what are the challenges of trials in pediatric oncology, a discussion about how we do this in practice in terms of global collaboration and how we operate this at sites, and then some examples of success. But I want to start with a sort of example to give you a sense of how this might work in clinical practice. So let's talk about this young guy. He's actually AI generated, but let's call him Kevin. He's a 4-year-old boy, comes into the emergency department with a couple of weeks history of abdominal distension. He looks pretty unwell. He's got a fever. He's got pain all over, and he has an ultrasound which shows that maybe he's got a mass in his abdomen, and he goes on to have cross-sectional imaging, and he has this CT scan of his chest and abdomen, and maybe the radiologist amongst you can see up here above the right kidney, which is down here, bright white, is this mass, which looks as though it's kind of in the liver. But if you could see this in 3 dimensions, this is actually tucked behind the liver. And so there's this large mass here in the back of the upper abdomen. And this is in an area where the adrenal gland sits, which raises the suspicion that this could be neuroblastoma. So already we're thinking that this patient might have a form of childhood cancer. And so we would potentially offer this patient enrollment on something called APEC 14B1, which is a biology study from the Children's Oncology Group. And that would then allow us to collect tumor samples from a biopsy of this tumor, blood samples, a baseline, germline samples, both from blood and from a buccal swab. To collect these samples, well, for what? So partly for research purposes, for us to quote unquote learn more about childhood cancer, partly because we actually need these results potentially for risk stratification, depending on what this turns out to be, and because often prior enrollment on a biology study is a prerequisite for being allowed to enroll on a subsequent clinical trial. So we go through all of that consent, we go forward, we do a biopsy, and we also do this thing called an MIBG scan, which is a way of staging potential suspected neuroblastoma. And again, don't need to go into the details, but this patient has got disease here. You can see some dark spots in the bones in the proximal tibia, the distal femur, in the hips, and as well the primary tumor in the abdomen. So this is now a patient we know has metastatic disease. We've got a biopsy confirming that this is neuroblastoma. And so essentially we've now made a diagnosis of high risk metastatic, which means that it's spread around the body, neuroblastoma, one of the most common forms of solid cancer in children. And so then we might think about enrolling this patient on an upfront randomized study, again from the Children's Oncology Group, which we'll talk a bit more about in a minute. And this name of the study, ANBL 2131, happens to be the randomized study that's open at the moment. And this is a study addressing a question of standardized chemotherapy versus upfront immunotherapy. So it's a randomization between those two. And so then we need to consent the patient. So we get out the consent form, and I'll just give you a moment to read this so that you'll be ready to consent in a minute. That's the first page. Here's the next. So just get all of that down. That's the next few pages. Give you a second to read that. And then, oh, there's another 40 pages of that to go through as well, which I didn't have the energy to put onto the slides. So I just kind of highlight all of that because that begins to raise some of the challenges about how we think about integrating research into clinical practice, because for these studies where we're trying to do research in the upfront, the initial management of patients with cancer, which is a large part of what we've done over the years to improve the outcomes, the conversations that we need to have at the beginning are actually incredibly long, detailed, and complicated, because at the same time as needing to explain a new diagnosis to families, explaining what cancer is, obviously that kind of devastating news about a childhood cancer, we're potentially also having to get into the nitty-gritty of a clinical trial, about what a randomization means. And it's a lot of information that one needs to get across in one go, probably not helped by our ever-lengthening consent forms. And so that one that I just sort of partly showed you, 50 pages of information that in theory has been mandated as being necessary for a family to provide informed consent. So we'll come back to some of those challenges later on in the talk, but that was just to kind of give a flavor. So for those who are not pediatric oncologists, let's just kind of take a step back and go to the beginning so that we know what we're talking about here in terms of childhood cancer. So this is a pie chart of the most common cancers that affect children. The most common diagnosis by far on its own is leukemia, typically acute lymphoblastic leukemia. So that's a blood cancer. And then the next biggest block you can see in orange are brain tumors, who I always think cheat a little bit because that's a whole range of different brain tumors under one bucket. And then you can see each of these slices are getting much smaller: lymphoma, soft tissue tumors, neuroblastoma is here, one of the most common extracranial, so non-brain tumors. And then you can see you get progressively smaller and smaller segments. So within the nature of childhood cancer, clearly lots of different diagnoses, all of which need their own individual treatment. And so that gets into this, oh, wrong button. That gets into this challenge that pediatric cancers as a whole are super rare. And so if you look at, this is data from Canada, the most common adult cancers, breast, prostate, lung, bowel, these are the annual number of cases for each of those. And if you take all childhood cancers, so that's across all of these diagnoses, it's this little red bar down here. So the total number of childhood cancer cases per year is less than 1,000, whereas these are all 20, 30,000 a year. So already the total numbers by far much lower. But of course, this cancer is not one thing. As we just said, it's a whole range of different diagnoses. And so within that, say, neuroblastoma, which I'll keep banging on about because it's my childhood cancer of particular interest, the total number of cases in Canada of patients with neuroblastoma, one of these childhood cancers, is about 80 a year. Only half of those will have that high-risk pattern that I showed at the beginning with metastatic disease. And then if we get into even more details, and begin to look at particular molecular subtypes of these cancers, we're really down to very small numbers. And so the reason why this is super important is because this really then impacts on how do we do research in these pretty rare diseases, because we very rarely will have enough patients within Canada to be able to run a study just on our own. And one could argue, well, why is this important in the first place if this is so rare compared to adult cancer? And the answer is that within childhood, cancers disproportionately cause mortality, and it's still one of the most common disease-related causes of death in the developed world. And so, we do have an obligation, rare as it is, to try and improve the outcome for these patients. So are we making progress in the outcome for these patients? And these are the sort of curves that as pediatric oncologists, we absolutely love showing and are pretty much mandatory for all of our presentations. So this figure on the left-hand side is kind of overall survival for a range of different cancers over time from the 1950s to the year 2000s. And you can see within this, this kind of dark green line, which is the leukemias, this line here, which is Hodgkin's lymphoma, and you can kind of pick your tumor of choice. The central message for all of these is that there's been a significant improvement in survival rates over time. And if you drill down that a bit more detail for ALL, the most common type of cancer that affects children, a blood cancer, you can see that in the 1960s and 70s, only around 20, 10, 30% of patients were long-term survivors. And through whatever we've managed to do, we've dramatically increased that survival now to north of 90%. So the question then is, what have we magically managed to do in this time? And the answer really is clinical research and clinical trials. So especially in leukemia, most of this improvement in outcomes has not come about because of some fantastic new drug that's been developed. It's actually because the drugs that we've had for many years, back from the 1950s and the 1960s, have been put together in complicated ways in well-designed international clinical trials where we've learned over time how to treat these cancers in a better and better way, how to select out which patients need which treatments. And so by using those treatments through progressive clinical trials, we've really managed to dramatically improve the outcome for those patients. So this is why pediatric oncologists kind of bang on about clinical trials so much, because it really has been able to, at least for some diseases, transform the outcome from near universally fatal to near universally survivable. Sadly, that's not the case with all cancers, but leukemia is really the poster child for that. And so then a few other kind of points to go into this in a bit more detail, that really childhood cancers you have to think about very differently from adult cancers, because although they both have the same name, cancer, there's fundamentally different diagnoses. So the cancers that adults get are typically carcinomas, which means that they've arisen from epithelial cells. They've come about through progressive damage from smoking, from UV light, from poor diet. And so breast cancer, lung cancer, prostate cancer, those diseases are fundamentally different from the diseases that children get. And the children cancers, as you maybe saw in that previous slide, are things like neuroblastoma, retinoblastoma, hepatoblastoma, nephroblastoma, medulloblastoma. What is blastoma? And so blastoma means that it's a cancer that comes about from a primitive cell. A blast is a primitive cell that we can't really tell what it is. And so these are cancers that have arisen not from mature lung or mature breast, but from very primitive cells during embryology, effectively, when these body organs were really being put together for the first time, and something somehow has gone wrong in that developmental pathway that then leads to these diagnoses. And so the diagnoses are different, and therefore, of course, the treatments need to be different. And the different diagnoses also then relates to completely different biology. So what drives childhood cancers is fundamentally different from what drives adult cancers. And so we need trials that are specific to childhood cancers. We can't just take what works in adults and assume that it will work in children. But of course, pediatric cancer is even more complicated than that, because, as I already said, we have a challenge from the outset that cancer in children is much less common than in adults. But as we learn more about childhood cancer, we're dividing it into smaller and smaller subgroups. So we divide up by the disease, say brain cancer, brain tumor. We divide up by the actual diagnosis, say medulloblastoma. And then within medulloblastoma, we now have multiple subtypes of medulloblastoma. And as we learn more and more about childhood cancers, we're getting into smaller and smaller subgroup based on particular molecular markers or other ways of risk stratifying. And so we're working with smaller and smaller groups. And this means that the trials have to be large in terms of geographic spread and the number of sites to enroll relatively small number of patients, which means that we end up with very high cost per patient. And it also means that drug development in pediatric oncology is very challenging because the actual market size at the end of the day for a drug company developing a drug in pediatrics is tiny compared to a drug that works in adults. And so often in terms of new drugs in pediatric oncology, I like to use this kind of metaphor of us relying on the crumbs that have dropped down to us from the adult table, because essentially drugs get developed for an adult oncology indication. And if it happens that it's also useful in pediatrics, so good, and we maybe get access to it and we can test it. But it's incredibly rare for a drug to be developed afresh for a pediatric cancer indication because of the small population. And then, of course, as everyone who works in pediatrics will be familiar with, life gets even more complicated because children are, going through dramatic changes, pretty, barn door and obvious, that a preterm infant and newborn are completely different from an 18-year-old adolescent on the cusp of adulthood. And yet all of these kind of encompassed under the world of pediatrics. And so that makes things very complicated in terms of PK, in terms of dosing, in terms of formulation. An adolescent who's 18 can probably take the tablet that's been developed for adults, but good luck getting a newborn baby to swallow a capsule that's, a centimeter in size. That's not going to work. And so formulation becomes really problematic as well. And then, of course, there's this challenge about the regulations and the ethical complexities of children. And I think for a long while, the sense in the regulatory field and even the ethical world has been children are really vulnerable. We've got to be super careful to protect them from the risk of participation in clinical research. We've got to do everything we can to protect those children from the risks of clinical research. And what we're really trying to push for as a community, and I think have been successful, there's still some way to go, is to say, well, that's true, but actually we've also got a duty to provide appropriate access to children to clinical research, because it's only through the clinical research that we will get to drug approvals for children and new therapies for children. And of course, that's relevant way beyond oncology. We know that many of the drugs we use in pediatrics are used off-label, which means that they've never been approved for that particular indication in children, which is because the research studies have never been done. And if we allow that situation to continue, we're actually doing a real disservice to children by saying the best that we can hope for is a drug being available, but without the good evidence to back it up. We really have an obligation to get more children into clinical trials, not for the fun of it, but so that we can generate the data to know that drugs can be used safely, which drugs can be used, what works, what doesn't work, what doses are safe. And so that applies to pediatric oncology, but also way beyond. Then there are yet more things to consider, which is that, as I've said, in oncology, we're increasingly interested in the particular genetic makeup of childhood cancers. And we're also then wanting to learn more about the biology of the cancers. I mentioned that biology study right at the beginning. And so we then want to think about, well, what samples could we collect through the study? And of course, in pediatrics, that's further complicated. Is it ethical to insist on a repeat biopsy for a patient when the purpose of that biopsy is only for research with no clinical benefit to the patient? Probably not. Whereas in an adult study, you could probably mandate that. Then there's the further challenges about blood. Even taking blood samples, you have to begin to think about children, what blood volume is actually available here. This nice figure here, putting it in terms of bottles of Coca-Cola, which is a slightly weird way to think about blood volumes, but clearly just making the point that the blood volume in a baby is much, much less than in an adult or an adolescent. And so the actual amount of blood that is available for you to take samples for research becomes limiting. You have to be careful about how many blood samples you're taking from an infant just for research purposes. And then, of course, the burden on the family in terms of hospital visits and how to think about the extra information that you might get from your biology studies and how that impacts on the family. What happens if you suddenly learn something about the patient's germline that was unexpected, but was possible for you to learn about from your genetic testing? How are you going to deal with those results with the family if you found something in research testing that also has implications for their life and maybe even other family members? And then Canada itself is a big challenge for pediatric oncology research. So Canada, of course, is huge. Pediatric cancer is rare, as we've talked about. And so although we have 16 centers across Canada that treat childhood cancer, making new drugs and making early phase trials available to patients is a real challenge. Pediatric cancer is rare. It's a national problem, but Canada is not well set up to deal with health issues on a national basis because, of course, healthcare is delivered provincially. And so that makes both clinical trials and actually clinical care very complicated. And as I'll talk about in a minute, most clinical trials are international, and Canada is part of all of these consortiums, but it's, of course, a separate jurisdiction when it comes to clinical trials. But on the other hand, that international border does create challenges in terms of clinical trials and does mean that we have a different regulator that clinical trials have to go through, which inevitably makes it much slower and more complicated to do trials on this side of the border if they've already started in the US. So that's enough kind of mooning about the challenges. Let's talk about how this might work in practice. And so I just want to let people know about this multitude, this word salad of different acronyms out there for all of the different consortium groups that are involved in clinical research. And the details kind of don't matter, but I think it's important to have a sense about the infrastructure that we're working in because it really informs how we work. So at least in North America, most research that we're involved in for childhood cancer comes under the umbrella of this thing called the Children's Oncology Group. I've chopped off part of their logo because the other bit of the logo says the world's childhood cancer experts, which somewhat annoys the rest of the world. So for political reasons, let's just stick with the Children's Oncology Group. So that Children's Oncology Group is under the auspices of the CTEP, which is the Cancer Therapy Evaluation Program, which itself is under the National Cancer Institute, which itself is under the NIH. The Children's Oncology Group, therefore, is ultimately funded by the NIH. And that means that on the one hand, there's funding available to run clinical trials through the Children's Oncology Group. And those trials tend to happen across all of the centers that treat childhood cancer in the US and historically Canada and some sites in Australia and New Zealand. But on the other hand, it means that this group also has to get approval for any trials it wants to do from the powers that be higher up in CTEP and the NCI. And so there's kind of a balance there, comparing it to the European model, which I'll show you in a minute, that on the one hand, there's a lot of centralized money available to run those clinical trials. But on the other hand, it means that the number of people that have to sign off on a clinical trial before it can happen is really huge. It has to be decided by a particular disease committee within COG, then endorsed by COG as a whole, then endorsed by the NCI, and only then can it actually go ahead. I put down here this logo of this other organization called C17, which is really instrumental to how childhood cancer research works in Canada, which is the Children's Oncology Group is based in the US. And so that means the COG cannot directly be responsible for the regulatory submissions of clinical trials in Canada because it has no corporate existence in Canada. And so what happens is that the C17, which is a organization, really small organization, actually in terms of numbers of staff, it's fewer than 6 people, runs all of these trials in Canada in terms of submitting to Health Canada the regulatory paperwork and being effectively the regulatory sponsor in Canada. And as people may have heard in the news, there's been a lot of challenge recently because of changes in the policies about NIH funding flowing overseas, about Canadian participation in the Children's Oncology Group. I think at the moment we are safe and we're still able to participate, but there's a lot of complications going on at the moment in terms of contracting and how money can flow across the border to help support our participation in the Children's Oncology Group. What you won't see here is any Canadian government logo because at the moment there is no Canadian equivalent to the NIH or the NCI that is funding these trials. So our participation in these trials relies on the funding that comes from NIH and NCI because they are the ones running the trials. And I've just put here this logo of the Pediatric Early Phase Clinical Trial Network, which is a phase 1 consortium, so early phase trial consortium that comes under this umbrella. So let's just contrast that with what goes on in Europe. And in Europe, it's actually a much more complicated and looser association because there's no national or international European equivalent to the Children's Oncology Group. There is this organization called PSYOP Europe, but it does not hold a huge pot of intergovernmental money. And so what happens in Europe is that each of the different diseases have their own consortium, which has been developed over the years, be that SciPen for neuroblastoma, EPSSG, which is soft tissue sarcoma, this relatively new consortium for osteosarcoma, one for renal tumors, a phase 1 consortium, ITCC. And then rather than these studies being run by one centralized group, the sponsor tends to be one specific hospital in Europe, be that in Paris or in Netherlands or in the UK, who acts as the global sponsor for that clinical trial. Somebody somewhere has had to raise some money from philanthropy or government to get the trial going. And then each country that participates in those studies has to find their money to participate in those studies. There's not this same model of centralized funding. And so kind of really two very different models on each side of the Atlantic, but increasing collaboration on a scientific level between the two so that we can kind of work together to kind of improve things globally. So how are we doing in Canada? And if people are interested, I put this QR code on here so you can go to the data. Sorry that the links just got cut off there. But these are data that are publicly available from CIPSI, which is the Children's Young People Cancer data that is maintained nationally, data available there. And these are relatively recent data that have been published on clinical trial enrollment for newly diagnosed patients in Canada. And so if you just take different examples, this is leukemia. The proportion of patients enrolled in trials from a kind of maximum of 70% has varied over the years, depending on whether there's been a trial available, because obviously once a trial is finished, sometimes there's a gap before the next trial comes on. But you can see generally the majority of patients are enrolled in an upfront trial. Whereas if you take non-CNS solid tumors, which of course is a whole range of different diagnoses, the actual percentage is a lot lower because it depends on whether trials are available or not. And you can see here across the different diagnoses, you know, we're really not doing quite as well in these non-solid tumors, in these non-liquid tumors, in having upfront clinical trials available. So historically, we've sort of said, you know, most newly diagnosed patients are enrolled on clinical trials. I think this data just shows that we're not doing as well at that as we would like to, and maybe not as well as we have done in the past at that, because of course, a lot of this depends on whether the trials are available. So let's talk about some practical aspects of how this works in reality. So one of the kind of philosophies we have in oncology is that treatment on trial is itself clinical care. And this comes with a whole bunch of advantages, but also some challenges. So on the advantages stake, I think, you know, we have as oncologists this mindset that we ought to be trying to learn from all of our patients if at all possible, and that the gold standard for all of our patients is to treat them as part of a clinical trial, because we always think there's more to be done. Either we're trying to improve the outcome for those patients because we're trying to make the treatment better to improve the survival rate because we're not doing well enough, or if we get to the point of actually having a really good survival outcome like we now have in leukemia, we're trying to think about, can we reduce the effects of the treatment? Can we reduce late toxicity? And so that we feel that there's always something that we can learn. I think it provides a smoother patient journey for the trial patients because they're not different from our standard of care patients. And in day-to-day practice, it's actually often challenging to tell who's on a trial, who's not on a trial, because the number of visits to the hospital, the type of treatment may actually be exactly the same. Often because if we're not treating a patient on a clinical trial, we're treating a patient per the protocol of a clinical trial because that's the best data that we have for how to treat that particular condition. And then I think, you know, we also need to recognize it does have huge benefits to us as oncologists in terms of research costs, because many aspects of what we need to do in terms of monitoring the patients, be that for toxicity, be that for disease evaluations, are what we would need to do anyway if we were treating them clinically. And so that actually does help to reduce the research specific costs, because a lot of those costs actually get wrapped up into the clinical basket because they are things that we would need to do anyway, even if a patient was not on a trial. And yes, we use those data for research outcomes, but they're not being done purely for research. So there's definitely a lot of advantages, but there's also quite a lot of challenges. I mean, certainly this requires significant staffing resources because the actual number of patients we're trying to enroll on trials, the number of trials we have to have open is large. And so that requires significant infrastructure in terms of clinical research associates, clinical research coordinators, who do all of this behind the scenes work about getting the trials activated. And then, of course, a huge job in extracting the data from the clinical chart into the databases so that we actually have that data in a way that is usable to interpret for the final outcome of the study. And then in addition, research nurses, research pharmacy, of course, really important in providing those resources. So a lot of money does need to be spent in having those people behind the scenes. And then related to this integration between clinical research and care, I've said that often it's hard to distinguish between a clinical trial patient and a non-trial patient on the ward. But that itself can be problematic because, of course, there are significant differences in reporting, documentation, and monitoring for patients who are on a trial versus not on a trial, even if they're getting exactly the same treatment. And so it can be very challenging to make sure that we are up to scratch in terms of recognizing and reporting and documenting adverse events, in terms of ensuring that we're capturing protocol deviations, in terms of ensuring that our clinical documentation is up to scratch in terms of research documentation. And going back to what I mentioned at the very beginning of this talk, the integration of clinical trials into clinical care is really complicated in practice because it means that there's a lot of discussion that needs to happen with families, especially if we're enrolling a patient up front, newly diagnosed in a clinical trial, and even more so if that trial has got a randomization, because then we need to explain the diagnosis, the implications of the diagnosis, what a clinical trial is, what we're trying to learn, what randomization is. And then, of course, for anyone who's done consent for a randomization, this really tricky balance between explaining the rationale for whatever the new arm is and why one would ever want to be on the new arm, versus at the same time, of course, maintaining clinical equipoise and not trying to oversell the benefits of that new arm. Because, of course, if we knew that that new arm was better and we wanted our patients to be enrolled on it, we shouldn't be doing a clinical trial. We should be, it's not ethical to do a randomization if we think we know the answer. So a lot of kind of challenges there that we can unpick later if people are interested. And so just to give a sense about who are the people that are involved in this, many of them have kind of joint clinical roles and research roles. And the way this works, I think, varies from site to site. And it does get very complicated once you get down to delegation logs, who's allowed to do what, and different rules between different sponsors as to who can do what. But, essentially the medical team, the physicians are there to provide the medical care and do the prescribing. But of course, there's an additional research role that is relevant for those physicians, that they have to have appropriate GCP training, they have to have appropriate protocol training. The PI has to provide oversight of everything that happens for the clinical trial at the site. Everyone needs to be on the delegation log. And that leads to challenges for fellows and trainees who are, depending on the study, sometimes part of the delegation log, sometimes not. Sometimes they are acting at the level of their clinical competency, overseen by a staff physician who is on the delegation log. It can get quite complicated there. Chemotherapy administration by the ward nurses is clearly critical for all of our patients. And then there's a challenge about, well, if you're giving a chemotherapy drug, which is a new drug is on the NOL, it's investigational, does every nurse that ever touches that drug need to be on the delegation log? And certainly one could argue that in practice, that's super complicated and challenging to do. And so we here have a practice of putting our nurse manager on the delegation log and then delegating responsibility to them to delegate responsibility to the nurses who are actually administering the drugs. Contact nurses, research nurses, nurse practitioners are very complicated because there's different understandings in different jurisdictions, different sponsors about what even is a nurse practitioner. Do we understand what they are allowed to do, what they're not allowed to do? The role of the CRAs, as I've mentioned, absolutely critical to everything we do in clinical research. And then the pharmacy, of course, involved in both providing the standard of care chemotherapy, but of course, crucial to the research drugs that may actually be exactly the same drugs as the standard of care, but sometimes will need research labeling, may need different study-specific supply, different logs behind the scenes in terms of accountability. So it really takes a very large group of people and is a complicated machine to keep going. And so this is just a few kind of practical examples here about how we do this. So at least at Sick Kids, we have Epic, and that's really helped to make clinical documentation a lot easier, because it's much easier to go back and add things to the notes that have been forgotten, or to add things to the notes without having to go and try and find a paper chart. And so all of the clinical documentation happens in there. And then we've got into a system where our CRAs help to generate medical oversight notes to capture the specific things like grading of AEs, or to document that we've reviewed X, Y, and Z results, to ensure that we have that medical oversight that is required for the patients who are on clinical trials. We capture adverse events within Epic. So Epic has this module where you can capture individual adverse events. It's all connected to what's called the CTCAE, which is a grading system for cancer related side effects, which kind of is everything you could possibly imagine. It's a big book, and it tells you how to grade that, be that a low hemoglobin or a snuffly nose or a pain in the leg, what grade it is. And we can then capture all of that within Epic. And then that allows oversight by the investigator to say, okay, I've reviewed this and I deem this related or not related. And then that can go on into the study database. And then again, in oncology, especially in solid tumor oncology and for brain tumors, it's really important that we have robust tumor measurements. And so at least at the moment, we get the clinical report that says this tumor has shrunk. But we additionally then go through and have a research fellow who documents specific tumor measurements according to specified guidelines that we then sign off and use as source data for tumor measurements that are used for response. So it's kind of a hybrid system between the routine clinical documentation with added extras for the clinical research components. So just want to end then by talking about a couple of examples of pediatric oncology trials and successes for how this has worked in practice. And I'm going to give two examples, one from leukemia and one from neuroblastoma. So the first is this drug called blinatumomab, which is a new and exciting type of immunotherapy, and it acts as what's called a bispecific T-cell engager. So it's made of two bits of antibody, but it's not itself an antibody. And essentially has one part of the molecule that recognizes CD19, which is a marker on pretty much all B lineage leukemia, and that's by far and away expressed by most ALL leukemia cells. And the other part of the molecule binds to CD3, which is a way of engaging T cells. So those are the T cells that come and have the ability to kill cells. And so by bringing these two cells together, you essentially trigger the T cell to kill the cancer cell, because you put a flag on this cancer cell to allow the T cells to recognize it. And so this drug was recently tested in a phase 3 randomized control trial for children with newly diagnosed standard risk B subtype acute lymphoblastic leukemia, the most common type of leukemia. The problematic thing of this drug is it has to be given as a 28-day continuous infusion. So pretty mind-blowing if you think about it in terms of the practicalities of that. This is a patient who needs to be connected to a drug, continuous infusion for a month. And luckily that doesn't need to be in hospital. They can take it home. And there was actually a team here at Sick Kids that developed these things called Blina backpacks, which was specifically designed to hold the kit and hold the bag of the drug, because of course the patient has to carry this around with them all the time. But this was a way of allowing patients to be at home and getting around and getting on with their lives. And so this was done in a randomized trial. Sorry, I got frozen for a minute. Sneak peeks of the future, and the results were actually really pretty staggering in terms of the benefit of this. So you can see the chemotherapy arm here in blue, already a really good disease-free survival. So this is at 3 years, 88% are free of disease. So that means that they have not had recurrence of their disease, hopefully a long-term cure. And with the blinatumomab, managed to improve that from 88 to 96%. So really, even with a great outcome, there's still significant improvement there. And this was, enough to get a paper in the New England Journal, and really now has changed the way that leukemia will be treated. This was a non-blinded study. Does that matter? I think probably not, because this is an objective outcome. It's based on disease recurrence. It's probably not one that is going to be impacted by the non-blinding. And the endpoint for this was disease-free survival. So why disease-free survival and not overall survival? Well, because there's lots of treatments that you could give to these patients in the event that they recurred. And so overall survival is going to be impacted by the treatment that you might give in relapse. And of course, also the study would take a lot longer to get to an outcome if you were looking for events of survival versus disease survival, because of course the relapse occurs before a patient might ultimately die from their disease. And so this data were enough for FDA and actually Health Canada approval of blinatumomab, and this is now a standard addition to the upfront treatment for leukemia. The other example I want to give is a bit of a longer story, which is of another drug called dinutuximab. So this is an antibody that we use in the treatment of neuroblastoma. So that's that solid tumor that tends to occur in the adrenal gland, the most common non-brain tumor, solid tumor in children. And so dinutuximab is an antibody against this thing called GD2, which is a marker on the surface of the neuroblastoma cells. And so there were lots and lots of initial academic studies to create this drug, to test its safety and to find out a dose. And then it went into a randomized phase 3 study. So the treatment for high-risk neuroblastoma is extremely long and complicated. Don't need to go into the details. But essentially, patients went through more than a year of treatment and then were randomized either to get this drug called retinoic acid, which had been used for years and years, or to get that retinoic acid plus this new combination of immune therapy, both with an antibody, this new drug, dinutuximab, and with 2 cytokines that were designed to stimulate the immune system and try and make it work better. And what were the results of this randomization? So again, a New England Journal paper, because this really transformed treatment. And you can see that the patients who got the immunotherapy arm had a significantly better, this is 2-year event-free survival. So this is 2 years without having a relapse, significantly better 2-year event-free survival than with the standard therapy. Relatively small number of patients here. You can see this is 113 in each arm. This is tiny in an adult context, but this was a massive international effort to get this done. And this was enough to lead to the approval of dinutuximab, and we now use it routinely at the end of treatment for high-risk neuroblastoma. But in fact, what's interesting is the world has moved on since then as well, which is that there was then a phase 2 trial of chemotherapy plus this antibody in patients with relapse disease. So this was not in the upfront setting, this was in the relapse setting. That showed that that was a really encouraging and useful combination, that idea of giving antibody together with chemotherapy. And that was then taken through into another study, this time in the upfront setting, saying, well, if chemo together with antibody is good in the relapse setting, maybe it's really good at the very beginning. So let's give patients who walk through the door that combination from the outset. And so there was a phase 2 trial that was done in one center, showed very encouraging results. And so the study that we're doing now, which is the study that I mentioned right at the very beginning, is this ongoing phase 3 study of chemotherapy versus chemotherapy plus antibody in upfront treatment. So this just kind of reflects how we've gone from antibody on its own in the maintenance setting, then testing it in relapse in combination, saying that combination is great, let's take that into the upfront in a single arm phase 2, and now move through to a pivotal phase 3 study. But of course, we're stuck waiting for the results of that in several years' time. So let's put it all together and then open the floor to some questions. So I think, I hope I've demonstrated that clinical trials really are critical and have been critical and remain critical for improving the outcome of for children with cancer. We know that our treatments for pretty much everyone with cancer are suboptimal, either because we're not able to cure everyone, or because if we are able to cure, that comes with dramatic, significant, lifelong late effects. And so we have to find a way to do better for all of those patients. I think we have been very fortunate in leading the way in integrating research into clinical care. And I think, it's useful to think about how that might work in other specialties, but it is, challenging to do. Oncology has always been very centralized at larger units, and that's both an advantage and a disadvantage. It makes it much easier to get research done, but of course it's very challenging for patients having to travel large distances. And so access, and in relation to that, resourcing, do remain major challenges, not just for the patients in the upfront studies, but especially for new drugs in the early phase trial context. And so I'll finish at that point, and happy to take any questions.
Thank you for watching this webinar brought to you by Increasing Capacity for Maternal and Pediatric Clinical Trials. Along with the Knowledge Hub, Impact also offers training awards to transform ideas into evidence-informed clinical trials with mentorship from parents, youth, and academic mentors. Each year, Impact organizes an annual meeting to share ideas and learn about new methods. Applications open in August for our fellowship competition that will start the following year in April. The Impact Summit is an annual meeting bringing together more than 100 leading experts in perinatal and pediatric trials. There are opportunities to sponsor webinars, a specific training award, or sponsor a portion of our yearly summit. These opportunities and other ways to work with Impact are all listed on our website, impacttrials.ca. Finally, we'd like to thank the Canadian Institutes of Health Research and all of our partner organizations which allow us to develop and